Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Imagine a cure for cancer so powerful that it actually comes with its own storm warning. I mean, a treatment that unleashes the full, raw force of your immune system against a tumor, but it requires an elite medical team standing by, ready to manage the fallout. Well, this isn't science fiction. This is the incredible world of immunotherapy. And today, we're going to dive into the amazing systems built to control its power.
And that right there is the heart of the issue. We're looking at a true breakthrough in cancer treatment, where the line between the cure and a full-blown crisis is razor thin. It makes managing the side effects a high-stakes mission all on its own.
So what is this weapon we're talking about? It's called CAR T-cell therapy, and it's truly revolutionary. We're talking about taking a patient's own immune cells, engineering them in a lab to become precision-guided cancer killers, and then putting them back in the body. The results have been absolutely incredible, giving hope where there used to be none. But this power is a classic double-edged sword. And here's the paradox of the whole thing. The dangerous side effects, they aren't a bug in the system. They're actually a feature. They happen because the therapy is working so well. It creates what's called a supraphysiologic immune response, basically a reaction that is way, way beyond what the body would ever do on its own. So the challenge isn't stopping the therapy, it's about learning how to control the storm it creates. Okay, so what is this storm exactly? Well, it mainly shows up as two distinct but related syndromes, and clinical teams have given them very specific names so they can identify them and, more importantly, fight them. They are cytokine release syndrome, or CRS for short, and immune effector cell-associated neurotoxicity syndrome, which thankfully has the much easier acronym ICANS. Let's start with CRS. You know, the easiest way to think about this is just a massive, body-wide inflammatory reaction. When those supercharged T cells go on the attack, they release a flood of inflammatory proteins called cytokines, and that signals other immune cells to join the fight, releasing even more cytokines. It's the immune response doing what it's supposed to do, just dialed up to 11. Now, the second threat is ICANS, and this one's different. It's a really complex disorder that specifically affects the brain. We're talking a whole range of neuropsychiatric symptoms, everything from just subtle confusion all the way to seizures or even a coma. And what's so critical to understand is that it's often kicked off by the chaos that CRS is already causing in the rest of the body. So, to make this super clear, there's a really powerful way to visualize the difference between these two. Think of CRS as a body-wide fire, a systemic inflammation that's just running rampant everywhere. ICANS, on the other hand, is more like a brain on fire, a localized but just as dangerous neuroinflammatory event happening right inside the central nervous system. Keeping these two ideas separate is key to understanding how doctors manage them. So you might be wondering, how does that body fire actually lead to a brain fire? Well, it all comes down to a critical link. The intense, body-wide inflammation from CRS can actually start to damage the blood-brain barrier, you know, that protective shield that normally keeps all the bad stuff out of our brain. Once that barrier is breached, those inflammatory cells and cytokines can just pour right in, sparking that secondary fire in the brain and kicking off ICANS. And that's exactly why managing CRS early is so important. All right, so knowing the threats is one thing, but detecting them is a whole other ballgame. You can't fight a fire you can't see, right? So, clinical teams have developed this incredibly effective early warning system, which is designed to turn what could be subjective symptoms into objective, measurable data. For the body fire, for CRS, the warning system is based on 3 key vital signs. First, a fever is almost always the initial spark that tells you CRS has begun. From there, clinicians grade how severe it is based on two major red flags for organ distress: hypotension, which is dangerously low blood pressure, and hypoxia, which is a drop in oxygen levels. The worse they get, the higher the grade, and the more aggressive the medical team has to be. Okay, that makes sense for the body. But what about the brain fire? I mean, measuring blood pressure is pretty straightforward, but how on earth do you objectively measure something as subtle as early confusion? How do you put a number on someone having trouble finding the right word, or a tiny dip in their attention span? Well, the solution they came up with is both simple and absolutely brilliant. It's called the ICE score, and this little test is the cornerstone of detecting ICANS. It's a simple 10-point bedside assessment that a nurse can do in about a minute. By asking the patient to do these 5 basic tasks: checking their orientation, naming a few objects, following commands, writing a sentence, and testing their attention, they get a real objective numerical score for that patient's cognitive function. A perfect score is a 10. And here is the absolutely crucial part. This isn't a one-and-done test. It's a surveillance tool. The nursing staff performs this ICE score at least 2 times a day on every single patient going through this therapy. And why? Because a drop from a 10 to a 9 or 9 to an 8, that is often the very first subtle sign that the brain fire of ICANS is starting to smolder. It lets the team jump in before it becomes a full-blown inferno. So, the alarm goes off, a fever spikes, or that icy score drops. What happens now? This is the moment the system triggers a rapid response, deploying a specialized team that has a crystal-clear playbook to get the situation under control. And the best part is, the triggers for calling in this elite unit, the rapid response team, are not left to guesswork. They are hardwired right into the hospital's protocols. A drop in that ICE score, a sudden need for oxygen, or a specific drop in blood pressure, these are all unambiguous, non-negotiable triggers. There's no debate. The alarm sounds and the team comes running. When the team arrives at the bedside, they don't just improvise. No way. They follow a strict, standardized protocol. First things first, they stabilize the patient's immediate life functions, their airway, breathing, and circulation. But right away, they also start ruling out other problems, like a bad infection, to make sure they're fighting the right fire. Then, they provide that initial support, like oxygen and IV fluids. The entire response is just controlled and methodical. And what holds this whole brilliant system together is something called Standardized Order Sets, or SOS. Think of these like a pre-planned mission playbook. When a doctor identifies a certain grade of toxicity, they can just activate the matching SOS. That immediately launches a whole cascade of pre-approved orders for nurses, for lab tests, for medications. It makes sure every single patient gets the exact right care instantly, and it dramatically cuts down on the chance of human error when the pressure is on. Okay, so the team is assembled, the playbook is open, now it's time to actually deploy the specific countermeasures. And this is not a one-size-fits-all situation. Fighting the body fire requires a totally different tool than fighting the brain fire. So there are really 2 main weapons in the arsenal here. For CRS, the go-to tool is a drug called tocilizumab. It's this really targeted therapy that blocks one of the key cytokines, IL-6, which is basically the primary fuel for that systemic body fire. But for ICANS, the treatment is different. High-dose corticosteroids like dexamethasone. These are powerful anti-inflammatories that can actually cross the blood-brain barrier and go to work reducing the inflammation in the brain. So 2 different problems, 2 very different targeted solutions. But of course, this leads to the most complex question of all. What do you do when a patient has significant CRS and significant ICANS happening at the exact same time? The CRS playbook says to use tocilizumab, but the ICANS playbook says give steroids. So which one do you pick? Well, the guiding principle here is crystal clear, and it's non-negotiable. You protect the brain first, period. If a patient has significant neurotoxicity, an ICANS grade of 2 or higher, the team starts high-dose corticosteroids immediately. They can still give the tocilizumab to help with the CRS, but it has to be given with the steroids. The neurologic threat always takes priority. So, as we start to wrap this up, it becomes really clear that this isn't just about one drug or one test. It's about a comprehensive system, with all these different layers of defense, all designed for one purpose: to make a revolutionary but dangerous therapy safe for patients. I mean, let's just quickly recap these layers. It all starts with proactive monitoring, using that ICE score to see the very first flicker of trouble. Then you have standardized grading to define the exact threat level. That triggers a rapid response team to get expertise to the bedside, who then use standardized order sets to execute a flawless response. And all of it is guided by clear rules for even the most complicated situations. It's just a beautiful symphony of systems thinking. And that really leaves us with a final and pretty profound thought. This entire intricate safety net was built just to manage the power of one type of therapy. As medicine keeps advancing and we unlock even more potent treatments against disease, the real question becomes, how are we going to build the even smarter, more responsive safety systems we'll need to manage the incredible power that we are about to unleash?
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.